Good afternoon. I'm Eddie Wong from Hong Kong, and I'm going to present my study, which is a review of assessment and diagnosis of childhood apraxic speech in Chinese speakers. This study was done by the amazing team, the author including me, Dr. Minnie Wong from Hong Kong, and Professor Shelley Filament from the US. Both of them are my PhD supervisors. I would like to start from reviewing the literatures about English speakers with CAS or CAS. There is a standardized test called DAMS for assessing the motor speech skills in children. Besides tests, tasks that use quantitative measures or transforming perceptual judgment to quantitative data, to quantitative data were also used, including the syllable repetition task, maximum performance task, and pulse marker. The other way of making diagnosis of CAS includes using a clinical checklist or use a set of useful tasks. Here are the common used clinical checklists and tasks. In order to make diagnosis of CAS, a diagnostic criteria should be adopted. Maximum performance task give a dyspraxia score. The score of 2 indicates the presence of CAS in the children. On the other hand, pulse marker index smaller than 94% indicates the presence of CAS. For syllable repetition task, 4 scores can be calculated. Each of the scores has a cutoff point to indicate the presence of CAS in the children. A set of relatively objective criteria was also used in the research. It requires transformations of perceptual judgment into quantitative data for the diagnosis. The details is listed here. Some other set of diagnostic criteria in research study include using the ASHA, 3 consensus features across different speaking contexts, and by using the strengths 10-point diagnostic checklist, children should show more than 3 out of 10 features across different assessment tasks. Most of the established tests or measures were developed based on English or Dutch speakers. It is not known how CAS was diagnosed in other languages, especially Chinese. Chinese is a syllable-timed language with lexical tones. It includes Mandarin and Cantonese. Mandarin is mainly spoken by the people in the mainland China and Taiwan. Cantonese is mainly spoken by the people in southern China, including Hong Kong and Macau. Mandarin has 4 tones and Cantonese has 6 lexical tones. The purpose of this study is to review the literature about the assessment and diagnosis of CAS in Chinese in terms of the assessment task, methods, diagnostic criteria and accuracy, and information about the examiners. We also examined the quality of diagnosis made in these research studies. This is the first ever review study that includes Chinese written article. This review is followed by the PRISM Scoping Reviews Guidelines and is divided into 5 parts. For the inclusion criteria, articles that publish in either peer-reviewed or non-peer-reviewed journals were included. We especially include unpublished master or doctoral thesis. The article or thesis should be published between 1980 January to 2020 October. They were written in English, traditional or simplified Chinese. The study should include at least 1 Chinese speaker with CAS, and the exclusion criteria were also listed here on the right. The article was searched in 7 English databases and 6 Chinese databases. The search terms are here. This is important to note that in Chinese term, the one on the left is traditional written Chinese, which is commonly used in Hong Kong and Taiwan, and the right one is simplified Chinese, which is commonly used in the mainland China, Singapore, Malaysia, and some other places in Southeast Asia. Before actual reviewing words, we conduct a pre-screening exercise that aimed to obtain consensus among the 3 reviewers. 100% agreement among the reviewers were obtained for the article inclusion or exclusion in the first round, while 100% agreement of the quality assessment was obtained at the 3rd round. An additional round for Chinese article between the 2 Chinese reviewers was conducted afterwards. 100% agreement was obtained in this additional round. This table shows the level of quality of the diagnosis in the article included. There are 4 levels. The highest level is using the reliable and valid test or method. Level 2 is using only objective data or criteria. The diagnosis in level 3 involved only perceptual judgment. The last level is level 4, which indicates the way of giving the CAS diagnosis in the article was unclear. There are sublevels in each level. We believe that the quality of the diagnosis will be higher if more criteria were used in the study. This diagram shows the procedures of including articles. 350 articles were identified from the initial search, and 5 articles were eventually included for full text review. Among the 5 articles, the first one was done by Wang 2017, which is a master thesis. It includes 2 Cantonese-speaking children with childhood apraxia of speech, and in the thesis, there are assessment tasks and a detailed assessment protocol was reported. The diagnosis of CAS was made by 2 speech and language pathologists with more than 10 years of clinical experience with 100% agreement. The criteria they used was 29 clinical features identified by a group of experts, plus the use of ASHA-3 consensus features. This study was rated as level 3A in terms of the quality of CAS diagnosis. The diagnosis of these children were made by The second study was conducted by Liu and colleagues at 2019. This is a treatment study published in a peer-reviewed journal. This study includes 6 Mandarin-speaking children with CAS, and the diagnosis of these children were made by 1 SLP by using the ASHA-3 consensus features. However, this is not clear how these features were determined on the children. The third study was done by Chen 2011. It was a master thesis. There were 5 Mandarin-speaking children with CAS. This is important to note that these children were diagnosed with CAS before enrolling to the studies. There is no information about the SLP's diagnosed CAS in these children. However, the author reported that the clinical features of these children, including delayed or limited babbling, non-speech grouping, inconsistent errors, sound substitutions or distortions, lower intelligibility, slow rate, and inconsistent tone errors. The fourth study was done by Wang et al. 2015. It is a case report of a treatment method for a Mandarin-speaking child with CAS. The diagnosis was made by 1 SLP, but no information of the assessment task diagnostic criteria were reported. However, the author reports that the child has 2 clinical features. They are prosodic deficits and articulatory grouping. The last study was done in China, which was conducted by Wang et al. 2018. It was a genetic study exploring the FOXP2 in Chinese speakers with CAS. The assessment task, diagnostic criteria, and the information of the examiners were not specified in this study. Therefore, the quality of the CAS diagnosis in this study was rated at level 4, which means unclear. In this study, we find that there is no report of standardized tests or quantitative measures used for diagnosing Chinese speakers with CAS. The most popular method was using perceptual judgment, and the current highest standard was expert perceptual judgment based on a set of clinical features. Obviously, there is a discrepancy of the available tools between Chinese and the international clinical practice. Secondly, the assessment task used by Wang 2017 that includes the imitation of polysyllables and DDK tasks were aligned with the English literatures, but validation of these tasks is needed for Chinese speakers. In addition, among the 5 studies, 2 studies share the same diagnostic criteria, which is using ASHA-3 consensus features. This is the only consensus that we can find in Chinese speakers to assist the diagnosis of CAS. There are some points that require future investigations. First, a valid and reliable tool or a quantitative measure for Chinese speakers is needed. Wang and colleagues 2021 and 2022 has provided a possible method, namely tone sequencing task. While waiting for the reliable and valid tool, some other existing tasks or measures can be adapted for Chinese speakers. Moreover, assessment protocol can be developed based on Wang 2017 and Liu and colleagues 2019 for Cantonese and Mandarin speakers respectively. Development of clinical checklist is also an option. Wang 29's clinical features from Wang 2017 has provided a basis for future investigations. Also, in order to understand the clinical manifestations of CAS in Chinese speakers or other tonal language speakers, direct investigation is absolutely needed. Lastly, cross-linguistic investigation is also important to determine the language universality and specificity of CAS clinical features. Here are the references of the studies. Thank you very much, and I'm pleased to be here to answer your questions. Thank you.